Hello, I'm Caroline Flint, the Trust Chair, and welcome to our public board meeting this morning. So welcome everybody. Can I just start by welcoming Priyanka Pereira, one of our new Associate Non-Executive Directors who's joining us today, and it's great to have you with us, Priyanka. Welcome. Just a couple of changes to the agenda, and this is really just to accommodate speakers who are arriving for a couple of items and pulling together. Following Rosie O'Connell, who's sharing her staff story as Head of Safeguarding, she'll follow with item 10, which is the Safeguarding Annual Report 22-23. We'll then return to the agenda order for item 7, which is my report. And then after item 11, Freedom to Speak Up report with Alison Flack, who's presenting on that, we'll take also item 14, which is the Mental Health and Learning Disabilities Collaborative Programme update involving Alison too. And I'm hoping, depending on timing and obviously contributions, we'll have a comfort break around 11 o'clock, which might be after finance and performance items. I hope that's okay with everybody. Obviously, I'll remind us as we go through some of those changes when we get to them. So I've had apologies from David Smith. David Smith is also one of our new Associate Non-Executive Directors, and Steve McGowan. I don't think there are any other apologies. I think we've got a full house here with us. Declarations, anything that anybody would like to raise in terms of what's on the agenda that poses a conflict of interest, please say, and remove yourself if necessary for that item. Any changes to the declarations, as usual, please let our Trust Secretary, Jenny Jones, know. Okay, nope, brilliant. Okay, we'll move on to the minutes, as are these an accurate record of the last meeting of the Trust Board. Is everybody happy with that? Any corrections in there that anybody would like to make? No, I can't see any hands up. Thanks very much. Any matters arising from the minutes or the action log? I've got one on the action log, but I'll come to all of you first. Anything that anybody would like to raise? No, thank you very much. Just on the action log, 159/23 about items delegated to committees. As colleagues will know, at September board, it was asked whether it was necessary for all annual reporting items to come to the board. Well, Michelle and I had a look at the document with Stella as well, and we've made some recommendations. I've circulated, there's some have been highlighted that could go to committees, and then committees could report through their assurance reports back to board. So there will always be a route back to board, but some suggestions have been made. I've circulated that to the non-executive directors for comments as you chair these committees, but I think also it's being circulated to EMT as well, just to get make sure we're all in the same space and happy with it. So I'm getting some comments back from non-executive directors. Obviously EMT members will let Michelle know, and we'll make progress on that hopefully once we've got all those comments in. So that's just really an update on that one. Okay. There's nothing else on the action log or the minutes. Are those minutes approved then? Yeah, brilliant. Thank you so much. And we'll move on to the staff story. And Rosie, welcome. Good to have you with us this morning. Hilary, did you want to say something before Rosie shares her staff story?
Yes, please. Yeah, we've got Rosie and we've got Chloe.
Sorry, Chloe.
A bit of a double act on it, I think it's really timely because we've got the annual report as well. It nicely gives the context to that, but I'm going to hand over to them. They're going to talk about what it's like to be a safeguarding practitioner, what it was that made them interested in that, and the difference that safeguarding makes as well. And you can see how hopefully through that and the annual report, the contribution that they make to the Trust strategic goals as well, particularly around quality, well-being, prevention, but also working in partnership, which is a big part of the team as well, working out as well as working into the Trust. So I'll hand over to Rosie and Chloe. I don't know who's going first.
It would be Chloe. Chloe's going to share the safeguarding practitioner role, and I will finish that off if that's all right with everyone.
Welcome, Chloe. Sorry I didn't mention then, but over to you.
No, not a problem. Can everybody hear me okay?
Yeah.
Lovely. Right. So my name is Chloe Greeken. And I'm here today to discuss my journey into safeguarding and give some insight into what it's like to be a member of the safeguarding team and the kind of work that we undertake. I was asked about what got me into safeguarding, and if I'm honest, it was my own lived experience as a child. People talk about adverse childhood experiences and the impact that this can have throughout a person's life. And for many, this is unfortunately a negative impact. But for me, I wanted to turn a negative into a positive and utilise my own lived experience to make a difference. I qualified as a social worker in 2014, but found that local authority children's social care was not for me. Rightly so, the focus is always on the child, but I found myself always looking at the parents and external family members and what support they needed in order to facilitate meaningful changes. I didn't feel like I was making a difference. So I moved into drug and alcohol services, and I stayed there for 8 years and loved every minute of it. One of my biggest strengths and passions was the safeguarding element of this role. I thought I would remain in drug and alcohol services, but when I saw that there was a job role for a safeguarding practitioner, I knew it was time to make a change and move into an area that I was passionate about. And here I am. So what does a safeguarding practitioner look like? Being a safeguarding practitioner look like day to day? Well, no 2 days are ever the same. We deal with anything and everything safeguarding related across a very extensive trust. This involves the day-to-day support of staff dealing with safeguarding issues and concerns, providing them with step-by-step guidance to ensure that relevant safeguarding actions are undertaken. We also attend various professionals meetings on a daily basis, as well as facilitating safeguarding training across the trust. The learning and development opportunities have been amazing within this role, and the learning curve over the past year has been an extensive one. I also like that you are encouraged to attend training wherever possible. In terms of challenges within this role, we are a victim of our own success. We are a very small team and the demand is high, but it certainly keeps you busy. There are many positive case examples that I could give to highlight the work that we do, but I wanted to reflect on one particular case that stuck out for me. I attended a professionals meeting for a young female patient that had recently given birth, and for various reasons, newborn was placed with birth dad and she was not living within the family home. Her mental health had spiralled and there were constant calls to the crisis service. During the meeting, I queried if mum was having contact with her baby. She wasn't, and there was no real clarification as to why. The impact, however, was clear to see. As a safeguarding practitioner, you are not only assessing risks, you are advocating for a person's human rights. And in this case, it was the human rights of both mum and her child. Having that understanding around the importance of mum and baby being able to form a meaningful attachment and the potential impact on both if this did not happen. As a result of this, I supported the key worker to escalate and highlight these concerns to the local authority and asked that supervised contact was facilitated. The outcome of this was that this was granted. The patient will never know that we were advocating on her behalf when she felt powerless and disenfranchised, but we were able to be her voice and facilitate a positive outcome. I felt like I had made a difference, and this is why I love this job.
Thank you, Chloe. It's fantastic. So if I can just finish that off and then I'll hand back to the chair. So earlier in the year, the Trust Safeguarding Plan for 23 to 26 was approved by the board. This plan, which was created with our patients, carers, staff and volunteers, is really closely aligned to the Trust strategy and goals. And it makes clear our safeguarding vision for the service, identifying 8 priority areas. Part of our vision is around having that safe and effective service for children, young people and adults, that empowered workforce that works in collaboration with patients and achieves those best outcomes, a perfect example given there by Chloe, and that visible and supportive safeguarding team alongside our senior leadership team who promote that positive culture. An element of that is being able to professionally and respectfully challenge our partners where it's believed that we're not getting the best outcome. And this example this is an example of us being able to do that and achieve the outcome. Chloe has provided an example which shows why our vision is so important and how the work of our practitioners in the safeguarding team delivering that plan can make a difference. Human rights, including the right to private and family life, is entrenched in safeguarding. And in this particular case, this is what motivated both Chloe and the clinician to work together. As Chloe has said, and I was a safeguarding practitioner before moving into this role, it can be challenging, but it can also be extremely rewarding. It involves working really closely alongside of our partners in other agencies and taking a collaborative approach to safeguarding concerns. And we couldn't achieve that without embracing that one workforce approach and having the strong relationship with our 3 safeguarding boards, our 3 safeguarding children partnerships, as well as the health place-based partnerships across Humber and North Yorkshire. Thank you very much for allowing Chloe to share a story. And I will now hand back to the chair.
Get myself off mute. Thanks very much, Rosie and Chloe. Should we take some comments and maybe some questions from colleagues, and then you might want to come back to the actual annual report and say something on that. We'll do that. We'll keep that a little bit separate at the moment. So thanks very much. Going back to colleagues then, and anyone would like to ask some questions, and I'm just looking for hands. Mike.
Thank you, Chloe. Thank you, Rosie. Excellent description. Love the case study. And I love the fact that you've used legislation positively for patient benefit. A lot of people in the chat say, oh, the Human Rights Act, we ought to get rid of it and all this. Well, I chair the Mental Health Legislation Committee, and I think legislation can be enabling as much as it can be restrictive. So I was really pleased to hear that. I'm pleased to hear that the effect on patients because of that. Thank you.
Thank you, Mike.
Thank you, Mike. Stuart.
Morning, Chloe and Rosie. I'm Stuart McKinnon-Evans. Really nice to see you and hear you. And thank you very much for your really interesting presentation and for the report later on in our agenda, which is full of very, very encouraging information about the great job you're doing. My question is about the way in which you work with the partner organisation. So you've kind of got a lot to handle, haven't you, in terms of relationships, time spent with others. And I wondered if you ever think the system itself, the way that the state is organised is a bit mad, and what could we do differently?
We do work really closely. We've the world of safeguarding, it wouldn't function without these partnerships. And myself, in the head of safeguarding named professional for adult safeguarding role, I do work closely with our adult boards, our children partnerships, and across all the ICB, the health place-based partnerships, and we do that really well. It's been encouraging over the last year or two to see actually that across the local authorities, because Humber is unique in that we work across 3 local authorities, and that does, it has in the past presented challenges when all 3 are doing different things. But what we are seeing now is that integration and they're talking to each other, and we're getting sort of more joined up approaches, and that is really beneficial for us as a provider trust, because we're now more or less doing the same thing rather than having to sort of deal with 3 different priorities, 3 different strands there. So there's certainly been a real significant improvement in how we are working together in the last year, and I anticipate that will continue.
That's really interesting. And sometimes it is useful to have more than one partner, because you can see how different people are trying different things out and pick from the best. So thanks for that. Good luck with all that. Thank you.
Thank you.
Thanks very much. Dean.
Yeah, thank you both. And just to echo comments from colleagues, really appreciated the update there and the annual report, which we had a good discussion at Quality Committee as well. But I just wondered, maybe for both of you, I guess a number of people on this call come into contact with safeguarding teams occasionally and know how distressing that can be. But you're exposed to that, a lot. And I wonder if you could just say a little bit more about the support that you get in terms of, emotional support, things that we could do more to support you in that clearly, as you said, distressing role at times, also rewarding, but just on the distressing bit, how do you feel supported?
I'll start, but by all means, Chloe, you come in as well. I'm aware of different roles. We actually, workforce wellbeing within safeguarding is something we have recently been discussing across all the boards and partnerships, recognising the traumatic element of the work that we do. We recently attended a conference. It was a launch of the Safeguarding Adults Week, and it was some of our consultant psychologists delivered a session on trauma-informed working and vicarious trauma through work. And we had a really good discussion about what we can do to support our workforces in terms of recognising the trauma. Within our team, we have a really good sort of supervision structure, but we also make time to take time out and give that permission. So myself as the manager of the team, it's really much a priority for me that we take the time out as a team. So we have recently looked at what we do as a team outside of the work, and we're have monthly sort of wellbeing sessions where we just have that, right, let's switch off work, let's go for a walk, let's do something, let's talk. And that's really important to us. We've had team days out where we get our colleagues in the workforce, an OD department, and they come and they'll do a day with us where we can really sort of work together as a team and think about what we're doing. So it's, I mean, the wellbeing offer from the trust I find is absolutely fantastic in terms of that support. And obviously we've got, our occupational health if we do need to have that discussions, but we are I think the safeguarding workforce is a resilient workforce, but we do need to make sure that we don't take that for granted, and we keep recognising just how important it is to have that restorative sort of supervision and support. Chloe, I don't know if you want to add anything at that point.
No, and I think just in general as a team as well, because we recognise the work that we do, we're such a supportive team to one another, and we're able to recognise. So if there's one team member that's, it's been a particularly bad day, like, we're so supportive of one another, and we're more than happy to pick up, additional workload. And yeah, we're very, very supportive of one another. We also have peer supervision, which we're given aside from general supervisions, where we just get together as staff members with no management there as well. And we're able to just have those open discussions and support each other. And I think we're all pretty good at sort of like looking after our own well-being outside of work as well, and we recognise the importance of that. And that's also discussed, like within our own supervisions by management as well, about just making sure that we're taking care of ourselves, because we preach this to everybody else within the trust, so we need to make sure we're taking care of ourselves as well.
Thanks, Chloe. Priyanka.
Rosie and Chloe, it's my first meeting, and it's such a good story to start with, and it's so inspiring, and thank you very much for that. Just my small question is, when you are providing these services, do you have like a backup for a cover? Because sometimes, however much genuinely with the interest of the patient that you act, and you might have instance where they come back and say that you have not acted in their interest, and how do you cover yourselves for protection in that sort of instance? I mean, like in sort of legal terms, or?
Yeah, I mean, we do deal with really complex cases within safeguarding, and you'll see in the annual report, they talk about the ever increasing risk and complexity across safeguarding. We do deal with that high level of risk there, and within safeguarding, when we're dealing with high levels of risk, with the certain sort of processes and mechanisms within the trust, but also within our partnerships, that allows us to really assess that risk and manage it. And it's not just a risk that we own, it's that, that we share it across our partners and own that risk and look at what we're going to do there. So in terms of, if heaven forbid something were to happen, it's about our evidencing of that work, and that evidence-based practice that we are considering what we are doing. We're looking at legislation, we're looking at our own experiences, and that again, that evidence-based, the frameworks, and all of that informs us to make the best decision we can for someone. So it is there, and I don't know if Hillary's got your hand up to come in at this point as well.
Yeah,
are you coming in to provide more, Hilary?
Yeah, just to add a bit more to that, really. The safeguarding team obviously don't work in isolation. The Deputy Director of Nursing is the overall manager of that service. And then I'm the obviously executive lead for safeguarding. So we regularly meet with the team. I regularly meet with Rosie. Every week we have a list of current cases, and we can have a discussion then. And myself and Kate's got a lot of experience as well in safeguarding. We can advise the team as well. And where we feel that we might need some legal advice on things, obviously we've got our legal team as well. So I think in terms of escalation, that I hope Rosie would agree that the team are very well supported with the senior staff and the executive.
Thank you.
Thank you, Hilary. Can I ask a question? Just go back to, Stuart's point about other agencies that are involved in this, and I was just interested about, I attended one of our trust huddles yesterday, and it was really interesting sort of seeing how different, obviously, colleagues from the organisation all inputted into that. Do you have, like, with your sort of, I suppose, local authority counterparts, do you have a similar type of huddle happening there, where you actually are talking to each other, not just, I'm not saying you are just relying on emails, but actually there's active discussion? So your example, Chloe, when you took that issue up, did you actually speak to somebody about your concerns?
So the first person I spoke to with regards to my concerns was Rosie. And then because we have an escalation process in place, that's been agreed with the local authority. So again, it's about that joint working, that open and honest communication, challenging where challenge is needed in order to best meet the needs of the person that we're supporting. And we always get a really good response to that.
Is that done by actually a conversation like we're having now, or is that reliant on, sending forms in or whatever? I'm not saying it is, but I just think it's useful to know that there is actually that sort of conversation happening.
Yeah, so the form leads to a then face-to-face discussion, whether that's done virtually or in person, but that the escalation form goes in, that will go to whoever the team lead is for that particular team, and then there will be the discussion had where sometimes it's just about that clarification around decision making and why they came to that outcome. So that it might be that the staff member that's working for the trust didn't have that understanding, so it's just that communication and information sharing is needed at that point. Or sometimes it's about challenging decision making and then looking at what outcome is needed and then how we can come to an agreement around that. But as I say, those conversations are always positive conversations. So yeah, and it facilitates good change.
Yeah, thank you for that. I think it's just, and as this is a public board as well, I think it's useful to know, because obviously whenever there's a serious case review, often, they look at the different services that work in this area, and it's communications and conversations that are really key to understanding, what's happened in a situation. So thank you for that. Are there any other questions? I can't see any other hands up. Chloe, thanks for sharing that example. I'm sure you've got hundreds of examples you could give, and Rosie likewise. But thank you very much for participating this morning. You're welcome to stay while Rosie moves on to the report, but if you have to get away, please do. Thanks very much. Okay, Rosie, over to you then, please.
Thank you, Chair. So here to present the annual report 22-23. So this presents the work of the safeguarding team and safeguarding activity across the trust for the last year. I know you've all got the papers and hoping you will have read it. So I think what I'll do today is just present and highlight some of the positive assurances and areas of focus, and then open it to discussion or questions, if that's okay. So in terms of those positive assurances, you'll see the report just shows just how much work does go into safeguarding across the trust every year by ourselves in the team, but also our staff and our leadership team across the trust. It's a really, a joint effort. We do and are meeting our statutory safeguarding requirements for both adults and children. We're very aware of what they are and what our responsibilities are in terms of safeguarding as a trust and as our professionals, and we continue to meet those duties. That includes making reports for safeguarding concerns where needed, participation within the safeguarding boards and partnerships amongst many of those. So it's really positive to see that work being completed despite the increase in demands and complexities across the service. Our safeguarding training compliance, really pleased to say that we are across all levels above 85% target. This has previously been a challenge across the trust, but we've undertaken a big piece of work with regards to our safeguarding training, looking at who needs to do what level and how do we make sure that we increase that compliance. Our colleagues in the workforce and learning department have been key with that as well, and we have now increase the compliance quite significantly, and that training is what gives our staff the knowledge and the skill and that confidence to be able to recognise and respond to safeguarding issues. We've also achieved our first co-produced piece of work across the plan. So, co-production across safeguarding has always been a real challenge because of the nature of the work and the sensitivity of it. But it was a real, priority of our team and the trust that we would start to co-produce. And in fact, the safeguarding plan was co-produced with our patients and staff. So Chloe actually did this piece of work with our youth action group, and it was around our domestic abuse gender, and we're really, really pleased to be able to present domestic abuse resources that have been co-produced with that group, and they really do give them a completely different sort of meaning and hopefully will be more useful and pertinent to our patient group. So really pleased in terms of some of those key areas. In terms of areas of focus, we've already sort of I've highlighted this, that increase in risk and complexity across safeguarding as a whole, and this is something we're not just seeing organisationally, we're seeing it across the safeguarding partnerships, and it's something that we discuss quite often in terms of what are we seeing and what do we need to do in terms of responding to this as a safeguarding family, if you like, across our communities. That obviously does lead to an increase in terms of demand on our safeguarding team. Last year we saw a significant increase, and it's maintaining at that high level. We have recruited to our safeguarding team, so we've got an increased number of practitioner roles within it, which is really positive in terms of being able to respond to that demand, and a real focus of us is to increase our visibility across the service. Coming out of the COVID pandemic where everything is over Teams, when we looked at the safeguarding plan for the trust, the overwhelming response from our staff is that they want the team and the senior leadership team to be more visible when it comes to safeguarding issues, and in being able to increase our numbers, we are getting out to be more visible, not only to our staff but to our patients in our inpatient units and hospitals, and we're seeing really good work in delivering that, and we're getting some really good feedback from our staff and patient group, and it's allowing us to have a better understanding of the challenges our staff are facing so that we can empower them in terms of that safeguarding skill. You'll see in the report there was an element of the adult concerns, a slight reduction there. We are proactively looking at that. It is picking up now when we look further through the quarters into this year, but we have started an audit on our referrals just to make sure that where referrals are necessary, they are going in. What it's the likely finding on that is in terms of our local authority partners are now introducing consultation lines, and this is for adults and children. So our professionals, our trust staff now have the ability to contact our local authorities and have that discussion about the issue before just putting in a referral form. So what we suspect is happening here is that we're seeing that slight reduction because where referrals were being put in previously that might have been inappropriate, they're now getting screened at those phone calls. And Chair, back to your point about that communication with the local authorities, it's really useful for us to have that communication with the local authorities and just be able to pick up the phone. So that is it. But we are, as I said, doing an audit around that just to make sure that that's absolutely what's happening. And we've got some work ongoing with our systems in terms of what we record and the data we collect, just to make it more robust and useful in terms of, hang on, if we've seen this reduction, we know where that's gone, we can explain why. So there's a lot of work going on with our systems team at the moment just to capture that, and that'll be really useful in terms of our reporting and analysis of safeguarding themes across the trust. So they're the highlights. As I say, I'll hand back to yourselves for any questions, or if anyone wants to come in at that point. And thank you.
You're on mute, Caroline.
Apologies. Thank you for that, Rosie. I repeat myself. First, Phil, and then Stuart. Phil.
Thanks, Rosie, for that report. Just to let the board know that obviously this has been to Quality Committee, and we were well assured. We were gratified to see the improvement in training of both children and adults. We liked the fact that there was a great breadth of input and that the safeguarding team had a great supportive role, and that it was well connected with partners, because we saw that all those sort of things are good success indicators of a successful team. So yeah, we were well assured at Quality. So thank you.
Thank you.
Thanks, Phil. Stuart.
Yeah, thanks, Rosie. I found the report really interesting, very well written and well presented just now, by the way. So well done for that. A couple of questions about kind of data. You explained the one about the understanding the differential trends between the different areas, and it probably highlights the point I made earlier that having comparisons is quite useful sometimes between different partners. My question was about the report, section 4.4 on the child looked after health team. There's some data there on what's happening in East Riding, but there's unless I missed it, there was no data on the other local authority areas. Is that a kind of a gap in the report, or was there something specific you wanted to highlight about East Riding?
It's we provide the looked after child service for the East Riding. We don't provide that for Hull. That's given by another provider. Yeah.
Thank you. Fine. Thank you.
Thank you, Stuart. I think that's quite interesting in the report. I picked up on that as well about the whole. It's partly the commissioning, isn't it, that has this impact about, the differences between, even though East Riding and Humber, and that obviously there was in the report increases in meeting requests because the 0 to 19 services, gotten to Humber, and so coping with those variations, I suppose, is the best word in terms of what's provided and the breadth of what's divided. I wanted to ask a question about looked after children and about them getting an initial health assessment. I think in the report it says it's dropped to 18% in the first 20 days. I think they're meant to get a health assessment in 20 days. Does it have to be a GP, or could it be another allied health professional that does that initial, if you like? I don't want to say use the term basic, because it's important that it's a good health assessment, but I just wondered, what the issue was there, and is it only reliant on a GP doing it? No offence to Phil, who is a GP here on the board, or any other GP, but I just wondered about that.
Yeah, we did have our named nurse for children looked after, Lisa Clark. She's very much linked in with our team, and she comes to our business meetings and gives these updates and provides these for the report. At that time, there was a discussion about that, and I believe in sort of the commissioning land, if you like, there were discussions about whether other professionals could do it, whether other nursing could do it. It's very much a GP role at that time, and at that time when the sort of reduction was there was one GP. Since then, we've been able to bring in another GP that can put in more appointment slots and complete more assessments. So we are sort of seeing that change, that trend there. But yeah, it's a question we did ask there, and I believe it's the GP role there in terms of those initial health assessments. Of course, nursing colleagues remain involved.
Okay, well, that's something to think about in terms of looking at the stats and what improvements can be made there, because obviously these children do need to get that that checked. Any other questions to Rosie on the report? I can't see it. As Phil said, it has been to Quality Committee, and it's had a good look at there, and assurance provided through that. We're just here to, I think, ratify this report. Is everyone in favour of doing that today? Yes. Thank you so much. Thank you, Rosie, and thank you, Chloe, so much. No doubt we'll see you again, not before too long. Take care. Have a good week.
Thank you, everyone. Thank you.
Thank you.
Thanks very much. And sorry, can I just, I had an overload of minutes. The minutes of the annual members meeting, item 5, is the board happy to approve those minutes? Thank you so much. Right. Okay. Moving on to the chair's report. Well, it's all there in terms of anything anybody would like to raise me. I just want to flag a couple of issues. First of all, fantastic staff awards the other week, celebration evening. Thanks for everyone on the board who contributed to that, and also special mention to comms for their work, and Anita Green, fantastic. I mean, at the end of the evening, yes, I was there till the end of the evening, not till as late as others, but anyway, the feedback from staff was just incredibly positive about it. And I think, Michelle, we're having a debrief, aren't we, with colleagues to think about for next year. But it was a really wonderful evening. Thanks for everybody who's inputted into the suggestions for changes to the committee effectiveness questionnaire, which we've incorporated to look at how we can make that questionnaire clearer and hopefully more effective for next year when we do the rounds of looking at how the committees are working. On the non-executive director champion roles, it's in the paper, but just to sort of say it here for the record, we are going to amalgamate the cybersecurity champion with the security management champion, and that person is Francis Patton, so thanks for that. But also, we had a bit of a discussion about renaming the flu NED champion as the vaccination NED champion, given, you know, obviously recent years with the COVID vaccination and what have you, and wider than that. But obviously it will still continue to have a focus on flu vac take up, and that is also Francis's role. And I just want to just really just say, since I wrote this report, thanks to Dean and Phil, who have agreed to undertake associate hospital managers training to meet the national guidelines of half of non-executive directors trained as associate hospital managers. So thank you for that. And there's some work going on with Mike and others to clarify the role for them going forward. So thank you. Any other questions to me on my chair's report? Happy with that? Thank you very much. Okay, we'll move on to the chief executive's report.
Caroline, Michelle's having to take an urgent call.
Oh,
so
sorry.
If you don't mind, I can just go through some of the highlights of the report.
That's perfect. Thank you. Thanks, Lynn. Thank you.
So key to the Chief Executive's report, there are 2 policies that require ratification today: the engaging and involving patients, families and staff following a patient safety incident policy, and the equality, diversity and inclusion policy. Michelle has continued to undertake quite a range of visits across services. As you can see from the director's elements of the report as well, visits continue to remain a very high priority for us. Good news that Kwame has now completed the undertaking in relation to his RO responsibilities. So he's taken those duties up from the 1st of November. But a thank you to Dr. Michael Desari, who did cover that period of time in order to enable Kwame to do that. In terms of awards, obviously, Caroline, you touched on the staff awards. I think we'd all agree that was a great night and a good success. We were, as you all know, shortlisted in the HSJ National Awards for our programme of work, Right Care, Right Person. And we were awarded a highly commended in relation to that, which is fantastic. And we're also really pleased that we have one of our social workers, Kirsten Bingham, who has been awarded Social Worker of the Year. So really positive news for us and Kirsten. Other than that, just around the system, as you can see, Michelle has highlighted a number of areas there. The Humber and North Yorkshire Mental Health, Learning Disability, Autism Collaborative held its 5th annual international conference. And again, that was a very successful, very well attended conference. Michelle was invited to lead a session at the NHS Providers Conference in Liverpool. Unfortunately, she couldn't attend in person. I did, but I followed her script really closely. So it was a good session around collaboratives and how they're sort of progressing across ICSs. Other than that, obviously, we do continue the work around NHS Impact. there is an expectation that there will be a framework for trusts coming about around governance of that ongoing work around continuous improvement. And we indeed are continuing to focus on developing an action plan in relation to that. Otherwise, Caroline, I'll pause there. It may well be that other director colleagues want to point out particular elements of their sections. Thank you.
Thanks very much, Lynn. Any director colleagues who would like to speak to some of the sections for them on this report? Just looking for any hands up there. Lynn, is that a legacy hand or is that your hand?
No, I'm just going to come back as Chief Operating Officer.
Okay, fine. Yeah, let's do that. Let's do that.
Obviously, the report.
And now Lynn Parkinson is the coup. Okay, okay.
I just wanted to touch on obviously where we are with operational plans. Carol, I think the report sort of explains that. But just in terms of our operational pressures, since the last board meeting, we have maintained an OPAL position of OPAL 2, sort of moderate pressures, which given where we are sort of at this point in time, I think that's a positive place overall to be. Obviously, we're not resting on our laurels. We're obviously continuing to focus on our winter plan. Obviously mindful of the potential still, although it does seem to be reducing somewhat around industrial action. The whole system as well has seen some pressures continuing, not surprisingly, sort of OPAL 3 position. Thinking about the system as it stands at the minute, it is starting to feel like it's getting a bit hotter in terms of sort of pressures and activities right now over the last sort of week or two. So I'm happy to pick up any questions, obviously. Thank you.
Thanks, Lynn. Okay, I can't see any of the other executive directors, so I'm going to go straight to hands up. I've got Stuart, then Francis, then Dean.
Thanks very much. A really good report again. Lots of information and some really good positive examples of where we're punching above our weight. So well done, everyone. My question is about this little section on exit interviews. And I'm thinking about we come to the performance report later on about turnover and exits. And we've got the salient risk in our risk register remains around staff retention and recruitment. And the report tells me that this is on page 48 of the pack, exit interviews. It tells me kind of that they happen and why we have them, but it doesn't tell me what they tell us. And I just want to understand kind of where that intelligence on the outcomes of the interviews is reviewed and understood.
Karen, would you like to get that?
Yes, certainly. So in terms of exit interviews, they are undertaken by
Karen, we can't hear you.
Can you hear me?
Yes, now. Yes, thank you.
Sorry. Maybe
it's okay. I don't know what happened there, but there we go.
Sorry.
Right.
So,
Karen, you've gone mute again. Karen, I'll tell you what. I'm going to take another question, which hopefully won't be on an HR issue, to allow you to sort out what's going the gremlins at your end, and we'll come back to the exit interviews. Is that okay? Thank you. Francis.
Thanks, Carol. I've got two questions and a couple of comments. The first one was on the winter plan bit, and it was just trying to understand from Lynn and stroke Pete, where are we on winter pressure fundings? What's the view in terms of money? You know, because things are getting tight. Are they going to fund what we need, and what impact would that have on us? And I can see Pete's hand going up immediately.
Pete.
So, rather disappointingly, no winter funding has been allocated for mental health this year. However, as a trust, we've been negotiating with the ICB as part of the H2 funding settlement. Some resources coming into the organisation that will give us the expectation to get break even, and we're just working our way through it and having a conversation at exec, because there may be the potential for us to have a small amount to be able to invest or shore up over winter. But as I said, disappointing, the national team haven't allocated a specific winter funding allocation for mental health this year.
And the impact of that on operations, Lynn?
Obviously, Francis, we had worked up and still do a number of schemes where we would want to focus additional funding is on continuing to reduce our out of area pressures over winter, and particularly in relation to older peoples, where we feel that we can bolster the out of hospital crisis pathways. We have 2 or 3 schemes that we would want to consider if we were in a position to have that winter funding available.
I think it's just worth noting as a board that we should note that the funding is not available, and the impact it might have. It's important we get that on record, I think.
Absolutely. How much did we get last year?
Sorry, Caroline, I went on mute. From memory,
sorry, I just wondered. Since we're getting nothing this year, what did we get last year?
I think it was about 190,000 off the top of my head. I'd have to go back and look, but it's not material funding that comes via the mental health winter, even when we do get an allocation.
Okay, thanks. So let's note that in the minutes, our concern, I think, at that, and put it on the record. Thank you very much. Francis, did you have another question?
Yeah, a second question and a couple of comments. The second question was on the CQC State of Care report. And just towards the end, it talks about the fact that it needs system approach to deal with it. I just wondered if there was a view from Lynn, but maybe it's Michelle, about how we think our ICB is doing in terms of tackling those particular issues and working together to do that.
Who would like to come back on that?
Hilary, do you want to pick that up in terms of sort of the focus around the ICB quality work?
Yeah.
At the minute, and I can comment more broadly around the partnership piece.
Yeah, that's fine. Yeah, so from the quality aspects in the ICB, they're picking up all of these issues. I mean, there's nothing in this report that's of any surprise, I think, to any of us. This is the context that within which we're working. But certainly, I think, as you can see, and certainly with the change of focus of the CQC, which will be picking up inspecting ICSs, that's the direction of travel. So there's a keen interest, obviously, in this report from the system and obviously the ICB as well. So it is featuring in all of the quality meetings, but it features anyway, because as I said, there's no surprises. So a lot of the things in here are already part of the strategic direction anyway across the system. I don't know, Lynn, if you wanted to add anything.
No, and I think that is translating. So there's a particular focus across our ICB about emergency and urgent care in relation to sort of impact on ambulance, wait times, etc. So there's a really high profile, Francis, around those areas that are hotspots. I think they're really well known. And I think that work is really starting to get sort of galvanised now in sort of some of the planning that's taking place. But obviously, as the Hilary says, no surprises in that report.
Okay.
And you had a couple of comments, Francis, I think.
Yeah, just 3. I wanted to say well done on the staff survey, which seems to be up on last year. We seem to have a higher uptake, so well done to the team on that. Really good news on the appraisal samples that we're doing to see quality, and hopefully that will feed into next year. Hopefully we discussed it at Workforce, and it's really good. And then I wanted to say well done to Kwame and the pharmacy apprentices. That looks a really good programme, and it seems to be really taking off. So just well done on those 3 areas.
Thanks very much, Francis. And you got there before me on some of those. And I noted on the pharmacy technicians and apprentices as well. It's such good, valuable work to the teams, the wider teams that they're embedded within as well. So great. Now I'm going to come back before I go to Dean. Karen, are you with us? Can we hear you?
Can you hear me?
We can hear you.
Good.
So exit interviews.
Yes, certainly. So going back to your question, Stuart, we report exit interviews into the deep dive report that goes into the Workforce and OD committee. So the Leaver deep dive report does a full and thorough kind of overview and under the skin of reasons for leaving, understanding why people go. I suppose what I would say with regards to exit interviews, we appreciate that there is more work required to get engagement. So we have good processes in place with that, but people often don't want to engage with exit interviews. But what I can say is that we are leading in the region in terms of our engagement with exit interviews, but at present it's at about 23.5%. So it gives us some intelligence, and we use that, and we use it to inform our strategies and into our deep dive report. But there is still that ongoing work that we've reported into EMT, and we've got a plan in terms of trying to get people more engaged with that process, because we do appreciate how important that intelligence is.
Thank you.
Is that all right, Stuart? Okay, Dean?
Thank you. It was just one for Hilary, just about the deprivation of liberty safeguards. It talks about the ongoing problems there, Hilary, and the impact on vulnerable patients. I know we picked up this a little bit at Mental Health Legislation Committee, but given it's in the report, I wonder if you could just say something about what that practically means for patients and any risks it creates for us as an organisation.
Currently, no risk for us as an organisation. Obviously, we were waiting, weren't we, to move to the new deprivation of liberty protection safeguards, but that has been moved now. The timescales on that have kept shifting. Obviously, if that does come in, there will be some risks for us as an organisation taking up that work. The direction of travel around that is going to improve for patients, because obviously they're trying to get it so that the assessments are done as near to care as possible. But at the moment, it's obviously still held by the local authorities. But the safeguarding team we've just heard from works so closely with the local authorities on this anyway. I feel at the moment that everybody is getting the care that they need. Our safeguarding team are involved, our staff are involved in those assessments as well. I think it was just a bit of frustration from everybody, because I think it's been talked about for so long about this shift. I mean, it must be about 5 years now. And we still haven't, we're not making the move, and there is no date at the moment when we're going to. So the minute we get anything on that, any clarity about moving to a date, obviously we'll do a full workup on what that will mean to the trust, because it will have some impact on capacity.
Thanks very much, Hilary. Kwame?
Yeah, Carol, I'm sure you are going to say that at some point, but I wanted for the board to join me in thanking Dr. Michael, who stepped in when Dr. Ben left as an interim medical director, and also having a long transition with me regarding the RO responsibility for me to do all the required training. So, and I would like that to be noted in the board minute. Just praise the thanks to Dr. Michael. Thank you.
Thanks very much, Kwame. Yes, let the record show we'd like to really thank Dr. Michael for his work, continuing work with, because he's not leaving the organisation. We've got a lot more we can get from Dr. Michael if you're listening. But thank you, Dr. Michael, for your role in the particularly the last sort of 6 months, and let that be recorded. And I can't see any other hands up. Now we have got 2 policies to ratify. Karen, I did sort of have a look at the one on the EDI and was looking for a little bit more consistency in language. Do you want to just alert the board to, I think some amendments are being made there?
Yeah, absolutely. So Caroline has pointed out for us that there are some inconsistencies throughout the EDI report in terms of the use of the word sex and the word gender. And just from a context perspective, this policy has seen the merger of the EDI policy and the transition at work policy. And what we have done is sought some advice from the Rainbow Badge Alliance, who obviously accredited us earlier this autumn as part of their scheme. So whilst the Equality Act itself still refers to sex as part of their terminology, it's more common now due to some of the nuances around, and particularly around trans, to use the word gender. But I totally note the comments, and what we're doing is just making a cross-check to make sure that where it's relevant to either one of those phrases, that we make sure that that's consistent and correct.
So what we're going to do is we're going to re-put sex in alongside any gender definitions, because sex is important, biological sex is important for health and legal reasons. So it will sit alongside other ways that people want to define their agenda.
Yeah, that's correct. So we can recirculate that for you.
Okay, thank you. So on that basis, if people are assured about that, are people happy to ratify? The first policy is the engaging involving patients, families and staff following a patient safety incident policy. Are people happy to do that? Thank you very much. And subject to those amendments, ratify the equality, diversity and inclusion policy. Brilliant. Thank you so much. Right. OK. So we are, Michelle, is Michelle with us, back with us, or is she still on her call? She's still on a call. OK, so we're going to move on in that case to the publications.
Sorry, I'm back.
Oh,
Chair.
Michelle
Sorry.
is back. Welcome back, Michelle. Publications and highlights report. Anything? Can I just say I thought the contributions by Leeds on this. The paragraphs were really helpful. It's really helpful having that sort of summary of some of the issues in these different reports that we can all read at our leisure another time, but it is really helpful having that. Michelle, anything else from you on this report? I think it's
no, just obviously you can see the scale of work that's going on. I think one of the things I'm sure Lynn would have picked up on is just the visibility of the visibility pieces. I think there's a lot of that and a lot of rich data, and just I'm sure we have just to formally acknowledge Kwame as the responsible, the RO. So congratulations on that. I know you would have mentioned it, but congratulations to me as well, because it's no mean feat getting over the numerous hurdles that one has to. So thank you, and also thank you. My thanks go to Dr. Michael Destiny, who's been acting into that post as well. But no, that's it. Thank you.
We have showered praise over Dr. Michael, and well deserved, and congratulations to Kwame. So okay, unless there's any other questions on the publications highlights report, that's noted. We'll move on, and we move to item 11 now, which is the Freedom to Speak Up report. We've got Alison with us. Alison.
Thank you. Morning, Caroline. Morning, everybody.
Morning.
Thank you. So this is the Freedom to Speak Up update report. We do bring an annual report on an annual basis. This is the 6-monthly update. Within it, you'll see some of the highlights and the work that's been happening with Speak Up. And we also have presenting today the newly revised Freedom to Speak Up policy and procedure, which has been developed in line with the National Guardian's Office guidance. So we are being asked to revise our policy in light of that, with the hope that we'll have this in place by January. I'm really pleased to say that the decision was made by the executive team that the mandatory training for Speak Up, it's now been made mandatory for all staff working in the trust. So I think that's really good, and we're being able to include that within our revised policy. We also, in this period, have had Speak Up Month in October, so I'm sure you saw lots of information about that, raising the awareness of speaking up and breaking barriers, and we were able to use the benefit of virtual and on all staff sessions, because we held a couple of staff sessions, and it was quite a good number. I know 50 is not a lot, but it is quite a lot to engage people in coming along to a lunchtime session, and there was lots of interaction and engagement, which also then produced us being asked to go to other teams and doing more visits. Just there is the table of how many Speak Up concerns we've received from the 1st of April up until the end of October, which is 23, which that was the full total for last year for the 12-month period. So slightly up. There's nothing, I don't think, to be particularly concerned about. And we continue to sort of triangulate that information with the other information that we've got. The other thing I just wanted to raise is we did, as part of our Speak Up Month campaign, run a ambassador recruitment, and we have got a number of people now who are interested in being ambassadors, and it was quite timely because the National Guardian's Office released some guidance on what can be expected from ambassadors. So we've just put in a kind of a selection process, and we're interviewing for Freedom to Speak Up ambassadors in the next couple of weeks. So hopefully we will have more people to join our team, but also out in the services where people said that they find it valuable to have people who they feel that they can relate to or who they might know to discuss concerns with more informally. They're just the headlines, Caroline. Thank you, and happy to take questions.
Thank you, Alison. Dean, would you like to, you're the NED lead on this area. Is there anything you'd like to add or a question asked?
No, reports appreciated, Alison, and we did have a report at the Workforce Committee as well. I'm the Trust Board lead, or the champion for Speak Up, and just so the board are aware that periodically Caroline, Michelle and I meet with Alison, and we go through the headlines of the cases and look for sorts of trends and issues and things that might be coming to concern, or able to scrutinise with Alison any sort of concerns that she has. But I wonder, Alison, just because the opportunities here in a public board meeting, I suppose, during the Workforce Committee, because we had the report not long after the Countess of Chester sort of revelations sort of came out, and there was a question to Alison about, if she was raising concerns with the chief executive or the board that she didn't think were taken seriously, what would she do? And I wonder, Alison, it just might be worth repeating that sort of response here in terms of the confidence that you have about how you would raise issues and concerns should you think that they weren't being taken seriously by people within the organisation.
Thank you. Thanks, Dean. Thanks. And just to add to that as well, in light of the Countess of Chester, clearly there's been more recommendations that we're expecting from the National Guardian's Office that we'll pick up. We've got a session, you'll see in the report, that I'm going along to meet with the consultants at their regular meeting to raise the profile of Speak Up, and we've also agreed that one of the consultants will take on the role of a Speak Up ambassador, so that's really good. I think if there were concerns, my first point of call would be Michelle as the executive director, clearly yourself, Dean, and Caroline as the chair, but also Hilary as a lead for safeguarding, or any of the exec I would like to think trust board I could approach. Clearly if the concerns were not being taken seriously, then as an independent person I do have the kind of route to go to Care Quality Commission, or indeed to the National Guardian's Office, who offer guidance and support.
Thank you. That's really good to
Thank
hear
you.
at this public board. I think that's really important. Thank you, Alison. Thanks, Dean. Stuart.
Yeah, Alison, thanks very much for the report, and Dean, thanks for explaining kind of what happens as a result. So I just want to sort of try and close some loops for my own understandings. So the report tells me about the policy and the level of activity with, I think, 23 instances of people speaking up.
Yes, yeah.
And then but it doesn't tell me kind of what the themes were. But then I'm thinking in other information that we get as the board, we have a log of incidents which are kind of including the freedom to speak up generated incidents, which tell us kind of what those issues were and how much has been done to close them, or some are outstanding. And so I wanted to just assure myself that we're seeing the full circle of from someone saying something to inquiry, investigation, if possible, going on to resolution, etc., which is good. I think if I've got that right, that's good. I can see that loop being closed. As far as the individuals who speak up are concerned, do they get to know the outcome of their action, and how does that happen? And I'm thinking that actually part of the culture is to encourage people to speak up. We'd ideally like those to be kind of false alarms, if you like, but it's important for people to know that if they contribute to the culture of reporting, that something is being done about it. So can you explain what is done for those people?
Of course. I mean, dependent on the type of concern, because we do get a full range, and some of our concerns we would directly signpost to our colleagues in the HR team, because it's about people's individual terms and conditions. So that gets picked up through that route. We would, again, what we try to do as well is to speak immediately to our colleagues in the operational divisions, and I have a direct link to Claire Jenkinson as the deputy coup in Humber to brief her on what the information is, if it's relevant. So the individual would get an opportunity to speak with Claire if they wanted to, confidentially, or I can take their concern forward on their behalf. As I said, depending on the level of it would be investigated, and then a response would be provided back to the individual staff member who's raising the concern. We also, in our process, we would follow up to check that, how people are, how things have moved on. And at the end of it, Michelle would, a letter goes from Michelle thanking the person for raising concerns, and asking them for any feedback to be provided to us. In the instances where we do commission independent investigations, which, there's not lots of those going on, we always try and manage them through the operational routes and the structures that we've got in place. Then a highlight sort of summary report would go back to the individual raising the concern. And in some respects, in some cases, Lynn has met individually with colleagues as well to brief them of the outcome of the concerns and listen to how they feel about it. The other thing that we do at the beginning when people contacted us to try and be clear about what are the outcomes that they would like to see. Because again, dependent on what the examples are that we're using would be dependent on the outcomes.
And just to say about, just on the loop, when Dean, Michelle and myself with Alison and sometimes Nikki's there as well, one of the guardians. When we have our I think quarterly updates, we go into, we go through each case and we talk about ones that are more appropriate to be referred to HR. And actually, I know for myself, you can see a correlation between some of those concerns being raised and where we look at them on our incidents report in part 2 board meetings. A correlation there. And we have had discussions, haven't we, Alison, about this thing about letting people know what's happening, because sometimes it can take quite a while. These investigations, we've talked about that, haven't we, quite a lot, about keeping people in the loop, feeling that things are happening and getting back to them as and when things develop. That's sort of the start. That's the style of conversations we're having at those quarterly liaison get-togethers. Dean.
Yeah, it was just to add to that, and I guess in terms of reassuring Stuart as well, that one of the things I look for, Stuart, is there's a danger, I think, that the speak up policy can become a sort of default grievance procedure for staff, and clearly if that's the best route for them to raise it, then we can signpost people, or Alison signpost people appropriately. But the reassuring thing for me, or assurance, is that there are concerns that are raised about, for example, staffing levels or delays to care, or appropriateness of risk assessments, etc. So seeing those is a really reassuring thing, that they come up, because you want to see those. And one of the things that I know that Michelle is often keen to ask is, are there areas where we're not getting concerns from, because that can be just as worrying as getting concerns, as it were. So that sort of sense checking in the organisation, and that's why I think that meeting is so helpful, just to give us that sort of overview, and to asking those sorts of questions about what is it that we don't know, and what are the themes that we've got sort of coming through, and also just if there's any sort of worrying trends about a particular area or a particular type of concern.
Thanks, Dean. Michelle.
Yeah, thank you. I mean, it's a really important topic, and thanks, Alison, for all the work in leading this as well. And obviously, we'll continue to develop the sort of feedback mechanisms, etc. But I do think it's relatively robust now. But I also want to thank the non-execs input. That's obviously the chair and Dean, because it's really helpful having those meetings. And I'm not sure other trusts would scrutinise quite as much as what we do, which I think is really good. And obviously we did that as part of the well-led as well. The main thing for me is to get as many ambassadors as we can, because I think, as we've pointed out, for me it's around this culture, and the people will know I'm completely obsessed with culture of the organisation. And the more ambassadors we have, the more we reach out to staff. Yes, there is an overlap sometimes with the HR processes, but I think between Karen and Alison, they've managed to sort those out, and we move people into the right areas, as it were. But this is about patient safety, and we've actually got some good examples now about where we have identified and supported patient safety. So it might be useful at some point, maybe at a strategic session, just going through some of those cases in a bit more detail, not the operational details, but just how things have changed and how we've used the freedom to speak up processes to make those service changes. But certainly thanks to the non-execs contribution, as well as Alison's particularly, and everybody else's. But thank you, Chair.
Thanks very much, Michelle. Alison, we're noting a report, but we also got to approve the revised policy and procedures. Is there anything you'd like to add on that report that we're going to approve?
Just as I said, Caroline, this has been revised in light of the NGO recommendations. So it's partly ours, and then partly some of theirs has been added.
National guidance.
It has been to the executive management team, and had some helpful comments. So I'm hoping they're all being reflected in the revised as well.
Great, lovely. Okay, thanks very much. Thank you, Alison. Hold yourself there, because we're coming back to you shortly. Everyone happy to approve the revised policy and procedures document? Thank you so much. Yes, great. Okay, now we are going to leap ahead to 14 and then come back for finance and performance. So Michelle and Alison are leading on this item on the Humber and North Yorkshire Integrated Care System Collaborative for Us, Mental Health and Learning Disabilities. Michelle, Alison.
Yeah, thank you. This is just, I'll pass over to Alison, obviously, as the leader. This is just the usual update of the work of the collaborative. A lot of positive assurances in there, and I just want to take this opportunity just to thank Alison for a really, really good, successful conference again, the international conference that started from small seeds and is now completely a huge annual event. So thank you for that. The most important thing for us is just to note the next planning round, which will obviously pick up in subsequent boards, but that will start in earnest over the next few weeks. But I'll pass over to Alison to give you the detail of the report. Thanks, Chair.
Thank you, Alison.
Thank you. Thanks. Quick change of hat. So just this is, as Michelle said, an update on the work that's happened around mental health, learning disability and autism collaborative. Lots happening. As Michelle said, really successful conference. Let's Talk Autism. Hopefully some of you were able to join us there. Really timely as well, as we've got Baroness Hollins, Professor Baroness Hollins, to speak on the day that her paper had been published. So very, very timely. We're also now really focusing on work around ADHD and autism as a system. So really looking at what we've got across the system and scoping that, looking at the waiting times and what is the capacity and resource and the pathways that we need to look at collectively. So happy to bring more back on that at a later date. The other thing that we're prioritising within the programme, Mike, do you want me to start?
Yeah, yes, just while I'm in the moment. You mentioned the ADHD across the network, and later on in the pack, we've got a 55-year timescale to reduce the waiting list. So I know there's no silver bullet to this, but what is the network doing as a whole to have some ammunition for commissioners or for government or whatever it needs? Because that's a frightening statistic.
That's the work that we're doing as a collaborative, as a network, as you said, to gather and scope with all of the providers of those services across the Humber and North Yorkshire area, with a view then to raising that through the Integrated Care Board executive, through our collaborative, to see what additional capacity and resource, and also what are the different pathways that are being utilised across the different providers. So really trying to get that work on a scope. So it is early days, but we're hoping in the next sort of 4 to 8 weeks that we'll have that scoping done and that picture collectively, so we can then sort of decide how we need to deal with it as a system.
Thank you.
Philip?
Thank you very much.
Yeah, it's just to reinforce that point. I mean, this is an area that nationally has changed completely. I can remember discussions 10 years ago when we had no service, for example, for adult ADHD in the area that I was working at the time. Is there some way that we can get a real national focus on this? Because the referral statistics and the change is massive, and unless it becomes a system priority, it will never get sorted. We need help. No one trust anywhere in the country can deal with this. It needs a focus. It's a real change in presentation, and therefore we need it's not something that can be tinkered with to sort. It needs a fundamental change.
Yeah, I think that's a really important question here, because again, it's about, there's lots of factors that are driving the uptick, isn't there? Some of which is, we can't just keep providing a service that gets bigger and bigger. We have to understand what's driving it and whether for some of those people it's the most appropriate route for them. So what's your thoughts on that, Alison? And
I think I'll just say a few things, then I don't know if Michelle wants to come in, but yeah, definitely national priority. We had Tom Carhill talking about it, the National Lead for Learning Disability and Autism, as part of our conference, and that's where we need to be plugging that into the planning, as Michelle said, for going forward, for funding for next year, but also looking at the capacity that we need, the workforce. It's a national challenge, as you said. The demand is like we've never seen before. So definitely we need to prioritise this, and working across the system is probably going to be the best way to do that. Michelle, I don't know if you want to add anything.
I think Phil was, correct me if I'm wrong, I think we're sort of saying how we might have to think about this differently.
Yeah, absolutely. But
not because rather than just create an ever bigger, sort of way of handling this, that is there something else we need to deal with here that is not just us, it's others, but also about what's driving people into this route for themselves, where there's clearly issues, but it may be that, you know, just making more and more assessments available are important, but that's not the only answer. I think that's what you were saying, Phil, wasn't it?
Yeah, it's not just about a contracting round or anything like that.
Exactly.
I think
It's
this
the whole
is
pathway.
a significant cultural change, isn't it, in the country, and mental health trusts are going to need significant support across the whole range of assessment, training, expectations, everything. And so it is something that we need national support with. Yeah.
Did you want to come in on this, Michelle, before I bring Stuart in?
Yeah, no, it is, and I think you're absolutely right. And I think Alison's touched on some other things. I mean, we need to link it into our planning for the first point, but we also need to discuss with the collaborative about how we deal with the current issues. So there's two bits for me. There's the current issues, which are the huge demand, and we've mapped that internally, and it is quite frightening and continues to be frightening. But we've got to deal with that platform at the moment as well. But then you're absolutely right, for we've got to look at how we stop the platform being on fire. So there is a change of pathway issue that we need to do. So not just the preventative piece, but you're right, it's that cultural expectation piece around people having a diagnosis and having something, because it is exponentially increasing. So we started those conversations with the regional team, because it's not just a member of matter of the collaborative doing some work, it's working with the larger regional team. And I've also started some higher level conversations with the national teams, and not just the mental health national teams, but the wider system teams, because I think we have got to look at it through a different lens. That will take time. But I think it will be productive, and we've started to have some really quite interesting conversations about how we do change it in a really different way. Do we move it to more mainstream? Do we start to identify it in a slightly different way? Do we work closer with the population, etc.? So I think we're looking at both platforms, and we have to keep an eye on both platforms. But we have to deal with the problem in front of us at the moment, which is how do we deal with the ever increasing numbers coming through, which is what we are doing through the planning process. But then also look at the future as well. And maybe we can pick that up at a later date when we start to have more conversations about that.
Thank you, Michelle. Stuart.
Michelle, you kind of prefigured my question there, and the distinction between kind of dealing with the here and now as opposed to what's in the future is really helpful. I wondered, Alison, though, about this kind of, if you've got a set of problems, you know, wicked issues, which are partly to reflect the way things are organised now, sometimes you have to kind of break the mould in order to kind of move on in a significant way, as opposed to, you know, collaborate nicely and be busy to no effect. To what extent do you think the kind of the culture of the collaboration is has its eye to recognising vested interests in a neutral way, the fact that organisations exist that can prevent things happening simply by the nature of the dynamic of their existence, and are people constantly talking about kind of breaking out of some of those cycles?
I think it's mixed, dependent on the wicked issue that you're dealing with, I would say, Stuart. But in relation to this issue, clearly there is a coalition of the willing, and organisations do want to work together. I think we've got a well-established collaborative, which was clearly led and set up with Michelle and myself some time ago, and I think we've worked through some of those sort of challenges around organisational sovereignty, should I say, and we're kind of moving forward to the next thing. Another good example of that is the work that we're doing on eliminating out of area placements, where we're looking at that across a much wider geographical picture with all of our mental health providers, which is something that we wouldn't have seen before. We're seeing much more transparency around where some of the individuals are placed and how much that's costing. And clearly we can do much more together on that larger footprint. But I would say it probably depends on kind of the issue that we're trying to tackle. But this, from what I've seen, is clearly one that everybody is prioritising and wants to get behind, because they can't solve it on their own.
Very interesting. Thank you.
Okay. Thank you very much. Any more questions? No, I can't see any more hands up. Thanks for that update, Alison. if I don't see you before, have a nice Christmas, but I might see you before.
Thank
There we
you,
go.
Caroline. Can I
All the
just
very
mention,
best.
sorry, can I just
Yeah.
brief, just to highlight really, just the work, that, particularly from a Humber perspective around the community mental health team transformation, and how fantastic that's been, and the benchmarking, how it compares regionally. And Humber has been the major contributor to that. So I just did want to flag that, because that's a real celebration of achievement and great for our patients and their families.
Absolutely, thank you. And if anybody wasn't able to attend the annual conference, there is a link available for you to dip in and have a look. If you haven't had the opportunity, I'm sure Jenny or someone could ping it round colleagues who might want to access it at their leisure. But thank you very much, Alison.
Thanks, Caroline. Thank you, everyone.
Thank you so much. Okay, we'll move on quickly then to the finance report, Pete, and followed by performance.
Lovely, thanks, Caroline. So this is the finance report as at the end of October. At month 7, we recorded a financial position consistent with what we reported to the board previously, namely that we're currently not achieving a break-even position, primarily in relation to the increased property charges at Whitby and Malton. For the benefit of the board, and the viewing public, I guess, our month 7 deficit position was a £286,000 deficit. That was driven by the property costs, and those property costs that increased after we'd agreed and set our operational plan with the ICB and do fall outside the control of the trust. They're almost dictated through policy and charging. In previous years, we've negotiated those cost increases with commissioners and the ICB, but obviously the block funding arrangement and the wider ICB financial position has made those conversations difficult this year. However, and I touched on this a little bit earlier, since I wrote this report, the additional funding that got released by NHSC into H2, we've allocated that across partners in the ICB, and that gives the trust sufficient resource to cover that cost pressure for the remainder of this year, and potentially have a conversation at EMT about a small bit of headroom. A couple of other bits quickly in the report, and then I'll move to questions. Our cash position does still remain strong, particularly for a trust of our size, and we continue to perform well on the Better Payment Practice Code. And you'll see in the report, agency expenditure has reduced comparative to previous years. We are still above our plan, but we are performing well when we compare ourselves to others. And we have had a bit of a deep dive on agency at both Finance and Workforce Committee, and we continue to see regular oversight at ODG and EMT. So that's a bit of a whistle-stop tour. Chair, happy to take any questions.
Thanks very much, Pete, and thanks for that update on some supported funding to us. Make sure that goes in the minutes and it's been reported here for us all to be aware of. That's great. Any questions to Pete? No. Okay, thank you very much, Pete. We'll move on to Dean. Apologies.
Sorry, Caroline, I wasn't quick enough. Not so much a question, Pete. It was just a sort of observation, really, that it just feels really positive report. We know, lots of pressures in the NHS and lots of organisations at this time of the year start to encounter problems. So just well done to you and the team in terms of the steady hand on those finances, which does mean that we can concentrate our efforts, can't we, on providing the care that we want to do. So thank you for that.
Thank you. And it's a team effort.
Thanks, Dean. Okay, moving on to the performance report.
Yep,
Pete,
so
do you want to kick off?
Yep. I'll just pull some highlights out, and then I'm happy to go straight to questions. So again, performance at the end of October. I think the report in its main, we had a look at this at EMT on Monday, and I think we all agreed that in the main performance is strong for the trust when they read the report, particularly in the context of the environment we operate in. If I can pull out a few items first before we move to questions. So whilst sickness and occupied bed days are flagging as red in the safer staffing dashboard, we do see assurance that all our care hours per patient day are green, which is a good indicator of the quality of care we're providing across our inpatient estate. We were really pleased at EMT to see the improvement in the performance in talking therapies on Monday, and we've exceeded the 6-week target now for 2 consecutive months from, where we were previously this year. So I think that's really positive. And we also noted the improvement in out of area. We're not at 0, but we've improved significantly, and I think that very much links with the delayed transfer of care petition for our mental health services. We've included on the front sheet the narrative on incidents. So whilst at trust level, we've exceeded the upper control limit, when we actually do the analysis for each of the divisions, we are in normal variation. And also attached to the report is the very detailed narrative on waiting times, which we had a good look at EMT as well. So I'll stop there, Caroline. Again, whistle stop till I think move straight to questions.
Okay, and unless Lynn wants to add anything, or do you want to wait for questions, Lynn?
I'll just wait for questions if that's okay. Caroline, obviously we've already discussed the position around neurodiversity. And yes, the figures are in the appendix report in detail. I think the challenge, as everybody has described, has already been covered. But no, I'll wait for questions. Thank you.
Okay, thanks very much. Hilary.
Yeah, if I could just give a little bit of context around the incident reporting, you can see there's two of our inpatient areas where we've seen quite an increase, but still within normal variation. Just to give that context is, I mean, this is obviously demonstrates the acuity on those units. We do expect every time that there's an incident on the unit within that 24-hour period that a datix is completed each time. So we don't just get one datix at the end of the shift that lists 5 or 6 different incidents. So obviously this is probably also why we see the numbers that we do, and that's the right thing to do, so that each incident is looked at separately. But also on the safer staffing dashboard, I think there's 2 units flagging, isn't there? There's stars and O's flagging around clinical supervision. We've just got the latest clinical supervision report in this week, and both of those are now compliant. So it's just a little blip, I think, in that month. I just wanted to add that for the board's context.
No, thanks very much, Hilary. Thank you. Any other comments or questions from colleagues? Stuart.
Yeah, thanks very much. I went through all of the graphs yesterday afternoon, trying to identify where are we on target, not on target, and if we're not on target, are things improving? Which led me to conclude that the kind of your summary of the picture, Pete, feels right to me. So I think there's a good correlation, and I think I also did a cross check against our risk assessment, and I think there's a good triangulation there between our risk and performance and the actions we've taken. So that made me feel quite comforted. And my question was, and the sort of the kind of the salient issue we've got is how to manage some of those waiting time trends and bring them back on track. And just as an example, I had a question. If you go to, it's page 141 of the pack, and it's about the 52-week wait lists for adults, and the graph, the higher graph in the paper about adult ASD, we can see the trend, heading really down towards that 0 figure, which is good. But the other trend around ADHD is just going up, right? So my question, and probably one for Lynn, I think, is, so having identified that, in one area you've got some really good success, but the other trend is going up, are you able to deploy resources between different teams to tackle the sort of the rising hotspot, as it were?
Good question. Lynn or Pete? Lynn, would you probably best for you, I think.
I can pick that up. Obviously, we do translate resource, particularly around children's ADHD and ASD. But I think given the numbers, Stuart, that we're seeing around ADHD, obviously the size and scale of the issue, we're limited in how much of that we can actually do. Whilst we try and be, very disciplined around the chronological order in which we see families and young people, but clearly there has to be some clinical triage as well. So that's where that team and labelling of resource happens, to make sure that we are seeing those children and families who have that more urgent need, obviously. But to do that with routine referrals is more difficult to do. We've obviously invested as a trust, specifically in ASD, which you know about, we've talked here. So, what I can say categorically through the capacity and demand work that we're doing, we're absolutely maximising all of the resource that we have available to us. And I hope that's the assurance that the board is getting from seeing this level of information in detail. So, when we're having conversations with the commissioners, I can absolutely say, we are being as proficient, efficient, productive as we can be, because we've done a huge amount of work to assess that position.
Yeah, and I'm sure you've got your hand on this tiller, Lynn, very much so. And the other interesting element for me about this report, it's in the kind of the more detailed appendix on waiting times, but it's the trend in trust referrals. That graph it's on page 158 of the pack, and the commentary is that the the number of referrals seems to be now going back to kind of pre-pandemic levels, which I think has got to be a sign of the encouragement, hasn't it? Albeit, as you say, the total resources we've got aren't sufficient even to manage that kind of level of demand in all its parts. But
Yeah,
I thought there's a sign of encouragement there.
Yeah, no, absolutely. I think that is really important. And we are seeing, particularly in those areas where we saw such a huge increase in demand, which again was particularly children's services. So we are seeing that tailing off, plateauing off. What we still are seeing, though, is that sort of pressure around urgency and complexity underpinning that picture. As well, and again specifically around children's services. So yes, there's some encouraging signs there, but still some pressures for the reasons that I've described. But yes, good point.
Thanks, Lynn. Thank you. Thanks,
Thank you.
Caroline.
Thank you, Francis, and then Phil.
Yeah, just a quick one for me. We at Workforce, we've seen all the excellent work on sickness and sickness coming down. But if you look at the safer staffing dashboard, there are 5 units which seem to be really struggling, as in over 10% in terms of Stars, PICU, Derwent, Ooze, and obviously CAMS. I just wondered if there was any comment on that, because we've been doing such good work overall. I wondered if Hilary wanted to pick up on those at all.
Yes, I can. And obviously these are picked up in the accountability reviews with all of the divisions. A lot of it is long-term sick, but then we've had, I think this is September, isn't it? Yeah, certainly October we started with a lot of upper respiratory infections as well, so it'll be interesting to see what the next dashboard looks like. But it is positive to note that some of them, I think Town and Court was one of them, that still got some high sickness, but it is much lower than it was. So it's just one that Lynn and I keep a constant watch on, making sure everything's in HR process around sickness absence as well to try and keep it down. But obviously, as I say, we pick it up in the accountability reviews with each of the division, and I'm certainly assured that they're all on top of it as much as they can be.
Okay, before I take Phil, did you have another question, Francis? Or is that okay? Thank you. Michelle, did you want to come in on that before I take Phil? Yeah, Michelle.
Yeah, just quickly, just to say, obviously, if you actually compare previous ones to now, there is a slight reduction. I know they're still high, but I think they're going in the right way. But what's interesting for me is the care hours per person per day, even with the sickness levels, are still good, which is obviously positive. So that doesn't mean that we don't need to work on the sickness aspect, and especially the short-term sickness and the medium-term sickness, which is we are doing. It's a bit more difficult with longer-term sickness, but obviously just keep an eye on that care per person per day, which I know that you are doing. But I think that's also an important indicator for us as well.
Thank you, Michelle. Phil?
Yeah, apart from a couple of the areas that we've spoken about, it's a very reassuring pattern is the performance report. I was just wondering, particularly around a lot of mental health trusts use triage as a key way to make sure that the most appropriate cases are seen, but I don't think I've seen any quality assurance about the triage process itself. It's often in primary care a source of significant frustration and the perception of inability to get patients seen. Is there any quality assurance work on the triage process in certain specialty areas? I'm thinking particularly around crisis and some of the neurodiversity referral pathways. And if not, could we maybe consider doing some of that work?
Lynn?
Yes, obviously there is monitoring of that and oversight, Philip, through the clinical routes and governance around triage processes, because you're absolutely right. We need to be continually assured that where we are clinically, and actually most of our clinical processes are very clinically focused as well. So given the nature of the work that we do. I mean, you just heard Alison Flack, for example, talk about the CMHT transformation, Philip, and I would say obviously a key focus of that has been access to services as well, particularly obviously from primary care. And we're really pleased with the level of activity, and a lot of that is direct face-to-face sort of first contacts happening within primary care, and obviously that's part of the clinical triage and assessment processes, but they do certainly happen. But I think it's a good point and I'll have a conversation with Paul Johnson, our clinical director. I think that maybe is a topic for us to explore in the quality committee in terms of an oversight of those processes.
Yeah, I'd like that, Lynn, and thank you for that response.
Yeah, and actually we heard earlier in the meeting about Kirsty Bingham becoming National Social Worker of the Year. I had a really interesting chat with Kirsty earlier in the week. I mean, it'd be useful also to know where our social work team are involved in this as well strategically, because obviously there's other issues outside of clinical that sometimes can be happening that are impacting on families and individuals that are also probably, I would suggest, quite important in terms of some of the triage work as well. So on that one, just listening between Phil and Lynn, I think a takeaway sort of maybe for the action log is to look at actually maybe at the quality committee having, whether you want to call it a deep dive, Phil, I'll leave that to you, but to have maybe a closer look at the triage system and how that's working. Is that all right for both of you, Lynn, Phil?
If that's all right with Lynn, I'd be delighted, yes.
Very happy with that, yes.
Great, lovely. All right, thank you. I cannot see any other hands up. If that's the case, thank you very much, Lynn, Pete, for the performance report. I suggest at this point we have a 10-minute break and come back at past. Yep. Brilliant. Lovely. Thank you. See you in 10 minutes. Welcome back to our public board meeting for Humber Trust this afternoon. The next item on the agenda is our emergency preparedness, resilience and response. And Lynn, you're going to lead on that. Thank you.
Yes, thank you, Chair. So this paper is the outcome of the annual process that we undertake around organisations, trusts across the NHS, assessing themselves against the EPRR core standards. As the paper describes, there was a very different changed process for this year, which involved us submitting evidence against the core standards to our ICB, and then an assessment process was undertaken by them. It did mean that the context, I guess, is quite important, that behind this, that more rigour is being applied nationally to emergency preparedness and planning. There has been some notable inquiries, particularly the Manchester bombings, people may well be aware of, and that probably contribute in an understandable way to scrutiny of the NHS's response to incidents of that nature. So elements of the core standards that hadn't previously been applied to us have been now. I think it's fair to say there's also been a bit of frustration across providers that the time that was sort of between the requirements being announced and being able to demonstrate compliance against them was quite short. So a lot of organisations sort of found themselves in a position where it just wasn't feasible and possible, given the application of those requirements weren't there previously. So it has meant that the outcome for us as an organisation is we are non-compliant with a position of 24% compliant against the overall position. What I will stress is we are not an outlier in that position whatsoever. In fact, in our ICB area, we're the second highest compliant organisation. So despite the frustrations, what we have done, and obviously you can see in the paper, is focused our attentions on ensuring that we've got the right plan in place to address where we need to undertake further work in order to achieve compliance next year. So it's been a lot of work as well happening collectively across our ICB in support of this process as well. As you can see, there'll also be oversight going forward around all organisations that are non-compliant, which is all providers in our area as it stands at the moment. So hopefully the paper sort of sets that out relatively clearly. But obviously, Caroline, happy to take any questions.
Yeah, I've got a couple of questions, but I'll go to everybody else first. Mike.
Thank you, Chair. I just wanted to say that Lynn has fully briefed me on the issues and the non-compliance across the piece. There are a couple of things on that. The spotlight won't be on us, but we are under pressure like all the trusts are. And the other thing is that there is a network out there, I think, so we'll hopefully learn from other trusts' experiences along the way to become compliant, hopefully. In what time scale, Lynn?
By the time the assessment takes place, Mike, next year.
Great.
The action plan has a range of actions within it, but all to achieve compliance within the process next year.
Yeah.
Okay.
Thank you.
Thank you, Mike. Stuart.
Thanks very much, Lynn. Sounds like quite a rigorous process. Hope was helpful. The kind of the toing and froing between NHSE and you and the team. I can see there's a plan in place, it's very clearly laid out. I was just interested, you know, the non-compliant elements around governance specifically. What are they?
Part of the requirements, Stuart, is a lot of the policies and procedures now that obviously are required in order to demonstrate compliance require annual reviews. And that is a change. They've moved from a 3-year annual cycle to a 1-year annual cycle. So we've had to accommodate that now in our governance arrangements to make sure that we can comply with that. I'm sure you can appreciate that's actually quite a difference between what was required previously.
But also reasonably
Sorry,
easily fixed, right?
Sorry, Stuart.
More activity, but reasonably easily fixed, that
Yes,
non-compliance.
yes, and all of that is obviously taken care of and within the action plan, and in order to achieve that. So yes, we can absolutely do it, and that's the focus of the work over the coming year.
Yeah, and a procedural level, Caroline. Not normally this plan would come to the audit committee before coming here. So will it come back to audit committee before the assessment is due to make sure we've got everything covered?
Yes.
Thank you.
Okay.
Thanks.
Thanks very much. Dean.
Thanks, Chair. And Lynn, I think I sense some exasperation in the way that you presented that. And I do wonder, because you rightly point out, don't you, this is an important issue for organisations on the back of those sorts of recent inquiries and also on the back of COVID. But I wonder, whether there were some feedback to NHS England to say, you're not going to get additional scrutiny if you do this in a timescale to which people can't comply with, and whether that's as a system wide we pass that feedback back, or as organisations. I think it's important. There's a two-way street. I think on it is serious, but it needs to fit into those sort of parameters. But then I've just got a couple of questions, really. Two things I think I didn't understand. One was at the start of the report, it talks about a deep dive and says that the deep dive is not part of the compliance process. I just don't know what I'd missed on that. And then at the end of the sort of action plan, there's a recommendation by NHSE that says EPR assurance should go to the board following completion of the annual assurance process. Whilst the annual work programme reports may well run financial year to financial year, submit calendar year, and referring to this year's assurance may be misleading. I just don't understand what the issue is with that. That seems like hyper bureaucracy, as it were, in terms of recommendation. And then thirdly, just on the action plan, any sense of sort of simulation exercises across the system in terms of planning and preparation? So I know there's an emphasis here on training, but those simulation exercises, for example, on cyber attack, so things that may affect us across the organisation in a different way to say mass casualty events may affect us as an organisation, and just whether there's any plans for those in terms of getting system-wide resilience. So apologies for that. That was a bit lengthy, wasn't it? But
in terms of your comment on sort of wider feedback around the process, Dean, there'll be no surprise that we had a meeting last week at ICB level with Amanda Bloor, as obviously the Chief Operating Officer, leads around emergency planning for our ICB. So that feedback is being collated and has been expressed. So, I'm satisfied that is happening. As you say, one of the key elements as well has been around the feasibility and access, and some of the training that we were required to declare compliance against actually isn't available and hasn't been available. So we wouldn't have been able to, and all organisations have found themselves in the same position. I'll have to double check that clause that you have just referred to, Dean. So I'll come back to you if you don't mind on that, just to clarify that position, make sure I've got the position on that correct. Because of the requirements, that it has initiated, no surprise, conversations about what we can do collectively together in order to achieve, support organisations to achieve compliance across the board where that is applicable, particularly around training. In terms of emergency planning exercises, those are already planned in, Dean. We do a lot of that collaboratively anyway, particularly between the local resilience forums, and we have participated in exercises and will continue to do so. Those are planned for the coming year. I hope that answers all of your points. I think it does.
Okay, thank you very much then. So some of the questions I was going to have been covered. I have to say, with some Humber North Yorkshire provider chairs, we touched on this at a meeting, informal meeting we had this week, so they're all involved in it. I'd have to say as well, I think some of the comments from some of the chairs was actually it's quite useful having this interrogation, because maybe actually you know, one of these things about these systems is you can end up in a process-driven situation, which then something awful happens, and for all the processes that are there, they don't actually add up. And if you think of the Manchester Arena thing, there were massive issues there around policing, about security staff, and so on. You know, it shows you that you have to keep going back and interrogating these systems. But clearly as well, it showed that there's a number of different agencies that have an in into this when something, you know, of an emergency can happen. Can I just so I'm clear, and Stuart picked up on it, in terms of us, obviously we've got the situation, we are asked to obviously approve the sign off for our submission today. On those areas where we weren't compliant or partially compliant, the part of the action plan would be to report back into the audit committee and then come back to board. Is there a schedule for how that will happen? Because I think it is just useful for us to sort of be aware of what has changed, but also I think pertinent to the point as well is not on everything, but on the key areas where we are having to relook, us as non-executives having a bit of a sense of what is the issue there. Is it just a change that we're going to have to do something annually rather than 3 years, or is it something that is going to require some substantial rethinking? I think understanding that is helpful to our assurance, I think. So when will it come back to board again in terms of progress, Lynn, and through what route?
So in terms of board, Karen, so just to be clear,
yeah,
this is reviewed monthly. The oversight is through the operational delivery group. Any issues or barriers to achieving the action plan obviously will be reported to E&T as a matter of escalation. Then I think, as Dean says, expectation that the plan is reviewed by the audit committee, and I guess it would be via escalation then from the audit committee to the board. But I absolutely assure you, if there are, as it stands at the minute, there's nothing flagging in our action plan that is a barrier to us achieving what we've set out to do in order to achieve compliance. However, if that were the case, I would obviously escalate through those routes.
Okay. I mean, obviously, it's important we have all these different committees that do this sort of thing, but when it comes to the board to sign something off, you know, are those of us who aren't on those committees, and so myself as chair, assuring myself as well. I see Stuart.
Yeah, so briefly on the timetable, it looks like if so, what you're saying, Lynn, you've got a plan with some dates in there of September 24 implementation. On the assumption that you don't need to escalate anything by exception, it seems to me, Caroline, that the audit committee there's a sort of an autumn audit committee prior to this equivalent board would be the assurance point, unless in the meantime Lynn flagged anything that was exceptionally out of plan.
Okay.
In order to be in advance of the AIM process commencing for next year, Stuart, is there an audit committee in May?
Yeah. Would
assurance to the May committee make sense?
Yeah, okay. It's May the 14th from memory. I don't know why I remember that, but it is.
Yeah. And that would be then picked up by the audit committee assurance report to board anyway, as well.
Yes.
Okay. So we're talking May time. Brilliant. Okay, that's really it's just helpful to just go away clarifying, you know, what's going to happen where and where it's going to be picked up. Okay, fine. So are people happy to agree and approve the statement of compliance going forward? Yeah, great. That's great. Thank you very much. And I put my agenda down somewhere in the midst of all that, and here it is. Thank you very much. Thanks, Lynn. We go on to item 16, Be Digital. Pete.
Thanks, Caroline. So this paper updates on some of the digital work that's happening across the trust. Variants of this paper have been to Executive, Operational Delivery Group and Finance Committee. Whilst I'll take the majority of the paper as read, a few key points I would pull out before we move to any questions is, pleased to say that we've now had our EPR funding agreement signed with NHSE. It's been a wee while to get that over the line, but that's now signed, which is positive. And we've got the EPR status report as an appendix. You know, really pleased that we've got the Be Digital Week coming up in December. So some comms have already gone out from that, and we've started sending packs out to the team, and there's a number of drop-in events being run during that week. You know, we are rolling out multi-factor authentication, which again is really good for our cybersecurity and protects the trust. you know, and I'm really pleased that, you know, in the last couple of weeks we did secure some additional funding from NHS Digital to improve the trust network and particularly bandwidth, which will build on our plans for next year as well. I've included in the paper a few updates on the work of the business intelligence team and what's happening with Interweave, because we're the host. But I'll stop there, and again, whistle stop, and I'm happy to take any questions.
Thanks, Pete. I think that was in the Chief Exec's report as well about the additional funding as well. So well done to everybody on that. Stuart.
Yeah, thank you, Pete. Very good report, very encouraging. It's a sustainability question, actually. What's happened to the 50 laptops that we're replacing each month?
We tend to bring back aged kit, Stuart, that's not fit for life, so we'll either recycle it or, and in the past, I'll have to double check, we used to sometimes donate them to schools, but I'm not sure whether we still do that. So rather than mislead, I will double check on that one.
There are some various organisations in terms of overseas and everything that have sort of gatherings of that sort of equipment as well. Stuart, anything else?
No, thanks.
Okay. Any other questions from anybody? No, thank you for that. The report is really helpful, easy to read and easy to understand, which is always good to see as well. So thanks to the team for that. Okay, moving on then to the Assurance Committee reports, and we'll start with Francis.
Thank you, Caroline. And a lot of this will cross-reference with some of the stuff Pete's already raised today. So the report's there. I'll pull out a couple of issues. We are reviewing our terms of reference now that we've taken on the digital agenda. So that will come back to board as part of the effectiveness review in May. In the terms of the insight report, as a committee, we pulled out how we felt that the forecast levels of outturn across NHSE, the ICS, just look unrealistic, and that many trusts seem to be unwilling to declare their true position, and that the second half of the year is going to be really difficult. And, you know, we could see quite a lot of involvement from NHSE in terms of efficiency and control. We thought that was something we should pull out. We did a half-year review of the position, which is in a good place, and we got good assurance that we could hit our year-end position, and Pete's updated on the Whitby and Malton property costs bit. And then in terms of the green plan, we congratulated the team on their achievements to date. There's been some really, really good work in there. A lot of other bits and pieces, but that's the ones I wanted to pull out. Happy to take any questions.
Thank you. Any questions to Francis? No, thank you very much, Francis, for that. Quality assurance, Phil.
Yeah, this assurance report is looking back to an extra quality meeting we had in September, where we take a lot of annual reports. So we looked at 7, one of which you've had today, which is the safeguarding annual report. We received good assurance as always, and with no major items to escalate. Just a couple of points to note is that we've agreed a process to regularly take in information from the Letby inquiry. We're going to have an interim report early next month and a formal report next March to Quality Committee, so that we keep up to date in any of the outputs from the Letby inquiry. And just something that we noticed in the clinical audit annual report was that there was several clinical audits, and it just said not started. And so we've just asked for an update on whether they're no longer going ahead and why, and if they are going ahead for actually a timescale. But other than that minor issue, we were well assured.
Thank you much, Phil. Okay, I can't see any hands up there. We'll move on to workforce.
Yeah, thank you very much. I thought I'd just start. This was a really good meeting, and as non-executive directors, in terms of seeking assurance, we look and scrutinise a lot of data, reports, graphs, do visits, check in with staff and patients as we speak to them around. But a lot of that reassurance comes from the people that present the reports, and this was a committee meeting that was really rich in content. And so just a shout out to Karen and her team, because I think that the way that they'd presented the reports, the way that they'd followed up actions from previous meetings, gave a lot of assurance, I think, to the board themselves, or sorry, the committee themselves, as went through these papers. So a lot of sort of content in which people were over their briefs and confident in reporting on, and that's always very reassuring. In terms of the content itself, we had a number of deep dive reports. So we get an insight report, which shows good progress in a number of areas. And then we tend to ask for deep dives to understand things a bit more. And you'll see on there, one of those is the DBS sort of deep dive report. And I think as a result of that deep dive, I can't think there'll be many organisations that have got the level of knowledge about sort of the numbers of outstanding DBS checks and the reasons for those. And again, as this is a public board meeting, just to reassure people that this isn't people that haven't been DBS checks, it's that there's a period of time in which they need to be renewed, and we're just having a look and an understanding of those, and some of those details are in there. We also had update reports from a number of subcommittees, again, where we saw really high levels of engagement. It was also pleasing to note engagement in terms of staff survey completion, flu jabs and COVID jabs that staff are having done, all good on there. A lot of indicators were going in the right direction and improving, but there were some of those that were still off target, which we've sort of captured in terms of the key risks to ensure that we keep a focus on there. And then finally, we approved the people strategy, which had been through a number of iterations and lots of engagement in the organisation, workshops and staff involvement in those networks and others that had sort of contributed to those. But happy to take any questions. You're on mute, Caroline.
Thank you very much, Dean. Okay, no questions there. And move on to Mental Health Legislation Committee, Mike. Or is Kwame going to do it? Are you going to do it, Mike?
Yes, I'm doing it. I chaired this meeting. I'm back in the driving seat. Thanks to Dean for chairing the last one. I want to repeat the comments that Dean said about report preparation. This was a meeting that has lasted 3 hours in the past. This meeting lasted an hour, and we covered the whole of the business in that time. And I was really pleased with the number of things in there. First of all, that you attended, Caroline. Secondly, that most things were in normal level of variation. Thirdly, that again, we celebrated the fact that restrictive intervention data is used in real time, so it's actually aiding clinical practice. So it's not just us sat in a boring committee just looking at data, we're actually listening to how the data is used. I'd like to speak just for a little while about Section 136, which is the police power of arrest and detention to a place of safety. We're working very closely with the police through Lynn and the Crisis Care Control Concorda and the relationships that Michelle's built up. And we're working together to reduce the number of Section 136s. This work ties in really well with the changes to the Mental Health Act that require police consultation before undertaking Section 136 arrest, of course, if it's all possible. So I think that all in all, it was a very positive meeting. And if anyone wants to ask any questions, fire away.
Thank you very much. No, thank you. Audit Committee, Stuart.
Thanks very much. Also a pretty busy committee earlier in November. I'm going to bring out some good news and one little concern, which we're not used to having from an audit committee, but we're on it. The good news is that we've comfortably meeting the standards expected of how an audit committee should run. You can see in my report lots of positive assurances around procurement processes, about the board assurance framework still shaping up in a good way. We always have a deep dive into a risk register at a divisional level, and this time it was the turn of the Forensic Services Division, which was very, very interesting about the kind of the very neat link between risk management and day-to-day operations that came through very strongly in the team's presentation. On the internal audit program, which is going to plan, we've got 3 reports receiving a significant assurance relating to volunteer recruitment, job planning and safer staffing. We've continued to have a busy counter-fraud programme for 23-24. And we spent quite a bit of time on the annual information governance report, which for me provided a lot of evidence that there's very strong leadership on information governance and good levels of assurance and activity in the future too planned. I mentioned earlier in the meeting, but I'll reiterate again, our review of the risk register still shows that risks relating to workforce and waiting times are the most salient, which echoes conversations about the performance report we had in this meeting earlier this morning. And then one little wrinkle was that one internal audit programme review about engagement with service users just showed up one kind of gap to be closed, which is, while there's good engagement with service users, it wasn't always clear what action was taken if they'd given feedback which suggested there should be improvement. That might be primarily to do with reporting and record keeping as opposed to lack of actual action, but we're going to close that loop. And I'm sure that will be dealt with quite soon. But once again, a good level of system level assurance, I mean, internal system level assurance of the control regime from that last meeting in November.
Thank you very much, Stuart, and flagging that particular issue you're going to look at regarding feedback from people raising things of concern through engagement with them. Any questions? No. Okay, thank you very much. Back to you, Stuart, Charitable Funds Committee.
Thank you very much. So charitable funds, some concerns here which are kind of been around for a while. So on the plus side, we've identified 3 main fundraising campaigns, which hadn't been so clearly identified until in the last few months. So they relate to a waiting room for CAMS, a day room at Malton, and generally a mental health campaign. They'll likely to have a kind of 12 to 18 month timeline for coming to fruition. And the other thing that's good is that we had identified a contribution from the Newby Trust of £80,000. We thought that might be a little bit at risk, but that trust has confirmed that the money's still available and the project now at the Inspire unit is going ahead, which is great. We've got now a regular discussion going amongst the managers in the trust who are responsible for each of the kind of pots of money, the fund zone managers. So that that group is getting together now more regularly to discuss how to spend funds already raised. Against that, however, on the KPIs of our fundraising, particularly, that remains red and doggedly red, with little prospect, I think, of the target being achieved this year, which is an issue we'll return to in due course. So that's the kind of the headlines from the charitable funds meeting.
Okay, thanks very much, Stuart. No hands up for that. Collaborative committee report.
Yeah, thanks. And to complete my set then, so once again, it's quite a detailed discussion we have at this meeting. You recall that there are 3 kind of work streams. This is about the specialist provider collaborative. All 3 work streams are now in the process of reviewing their sort of next developments. That's the kind of the longer term picture. On the positive side, the number of young people in CAMS requiring out of area care is reducing, which is starting to be is a good sign. And we're seeing quite a long-term trend in the reduction of the population, the number of cases in the adult secure, medium and low settings. You can see that trend happening quite consistently since the collaborative started. And on the risk side, actually less operational and some financial risks emerging, which we're keeping a close eye on, related to specifically packages of care and adult eating disorders. But we think that those are manageable within the scheme of things at the moment. So those are the kind of key highlights from the last meeting.
Okay. Any questions on that? No. I was able to attend finance and investment, workforce, mental health, ledge and charitable funds since the last board meeting. And just to two things. First of all, to say to Dean and Stuart, thank you very much for the very quick turnaround you did to make sure we had your assurance papers for this board meeting. I think, you know, trying to have, you know, when you're discussing issues at committee, as live as possible and as topical as possible to these meetings is really, really helpful. But I can vouch for everything that's been said. Each of those committees I attended since the last board, it was a very fulsome discussion and with lots of participation from everybody. And I think the papers were a really good quality as well. And I, as obviously not a member on all these committees, I really appreciated that opportunity to observe, because it really helps me when at board I see the papers come through and what they're all about. So thank you to the chairs of all those committees and all the participants. Really appreciate it, and the work that goes in by staff, particularly those doing the minutes and turning the papers around and everything else. The assurance, thank you. Great. Moving on then to item 24, December, the board strategic development agenda. I mean, you can see the agenda there. We're very much focusing, as agreed, on the primary care plan update. So that is the main part of the meeting, but also a little bit of reflection on how the strategic board development meetings a programme of work, because this is quite new for us in 23. The arrangements we went to, which is to have alternate public boards with strategic board meetings. So I will be circulating, probably just Stella's doing me some slides, but just a sort of what the forward plan is looking like for 24 to get some input. And I think part of the challenge, and Stella, Michelle and I, we've had conversations about this, haven't we, is about how we make sure that we don't overload those meetings, focus on the strategic, so that we can really have some full discussions there that then weave back into the board itself. And you can see from my chair's report, at the last strategic board, we actually discussed the NHS impact, improving patients together, care together. And one of the actions that came out of that was to look at how we could look at those assessment themes being woven into both board and committees. So I feel like we're working on it, but there's some good synergy going on between, you know, public board and those strategic meetings. And I hope other colleagues feel that we're getting there, we're getting that flow, but we'll have a chance to talk about that in December. Anything else on that from anybody? No? Great. Moving on to item 25. I have no items flagged to me for escalation. There's no any other urgent business. Review of the meeting. Again, thank you to everybody who worked really hard to get the papers into Jenny. It makes Jenny's job a lot easier. But we, apart from a few for reasonable explanation, we met our deadline of getting the board papers out to everybody on the Wednesday morning with 5 full working days for everybody. And that's particularly important, I know, for non-executive directors in this who may have been seeing some things for the first time. So I really appreciate all the work that's gone into making that happen. Any comments from anybody on the papers? Were they helpful? I think it was, you know, I think we've seen, I feel like actually there's been a real uptick in terms of some of the papers we've received this year, getting better and better, and it's appreciated. But any other comments from anybody in terms of the meeting today? No? Everybody happy? Everybody felt they had their chance to have their say? Great, lovely. That's brilliant. Priyanka, how have you, well, I don't want to, you might want to tell me privately, Priyanka, what you feel about this is your first thing, but I hope you've enjoyed yourself today and taken away some things to think about from it and that are helpful.
Yeah, thank you very much. Yes, I've enjoyed it, and I've sort of got a lot of information, and everybody who spoke with me through the introductory meetings have given a lot of good advice and a lot of good information, which I'm sort of digesting quite rapidly. Yes, but it's been a good meeting. Thank you very much.
Thank you so much, Priyanka. So great, lovely. Our next public board meeting is on Wednesday, the 31st of January, 2024. My goodness, where did 2023 go to? I will now close formally the public board meeting. Thank you to everybody who's viewing or may view at a later date. Thank you.